Good morning everyone. Today the class is about osteoarticular tuberculosis, that is skeletal tuberculosis. Bone tuberculosis. Spine is the most common area involved. The involvement of spine tuberculosis is called pot spine. 50% of all cases of skeletal tuberculosis occurs in the spot spine. Joints, tubercular arthritis. Mostly it is involved in the order of hip joint, knee joint and triple deformity, shoulder joint, otherwise called caricica, elbow joint, wrist and carpus, and sacroiliac joints. It also involves long bones and causes tubercular osteomyelitis. It also involves the short bones, that is bones of the hand and the foot, which is called tubercular dactylitis, otherwise called spina ventrosa. Coming to the tuberculosis of the spine, it is first described by Sir Percival Spot in 1779, hence the name Pott's disease. Usually two continuous vertebrae involved, but several vertebrae may be affected, that is called skin skip lesions, and solitary vertebral involvement may also occur. Skip lesions 4 to 10% of the cases, 12% of the cases as associated other osteoarticular tuberculosis involvement. Clinical features: any age group tuberculosis may occur, majority less than 30 years, male, female, the predisposition is same. It is rare in the first year of life. When it occurs, it is more severe. So the constitutional symptoms wherever the tuberculosis in our body includes malaise, loss of weight, appetite, night sweats, evening rise of temperature. The clinical features, that is the specific symptoms of tuberculosis involving the spine, are pain or night cries. That is, the patient will be able to sleep, but they will get up from the sleep in middle of the night. That is due to the loss of spasm of the muscle during the night time. Stiffness or spasm of vertebral muscles, localized or persistent backache, deformity, restricted range of motions, enlarged adjacent lymph nodes, abscess and sinuses, and neurological deficit. The neurological complications: 10 to 30% of the spine TB will be associated with neurological deficit. First 3 decades are most common age involved. The disease below L1 vertebra rarely causes paraplegia. Highest incidence of paraplegia, that is the involvement of lower thoracic vertebra. Commonest pathology for non-traumatic paraplegia in developing countries still remains to be tuberculosis. Staging of neurological deficit involving the tuberculosis are stage 1, 2, 3, 4 explained by Tuli or Kumar's staging of paraplegia, that is stage 1 is negligible. The patients are unaware of the neurological deficit, that is there is no symptom but the sign is present. The sign is extensor, exaggerated plantar extensor as well as ankle clonus. In stage 2 it is mild, they are aware of the deficit but they can be able to walk with support. Stage 3 moderate, they are not able to walk even with support, and also involvement of sensory deficit is less than 50%. In severe cases, they are not able to walk, sensory deficit is more than 50%, and they will have sphincter, bladder and bowel involvement. The clinical features of Pott's paraplegia include paraplegia itself, that is very rare, spontaneous muscle twitching in lower limbs, clumsiness while walking, extensor plantar response, exaggerated reflexes, that is ankle clonus and motor is affected first, then sensory. The sense of position and vibration is the last to disappear. Regional distribution of spine TB. Most common is going to be always dorsal, then it is going to be lumbar, then dorsal-lumbar and cervical, followed by cervico-dorsal and lumbosacral. Types of vertebral lesion: 5 types. Usually adjacent vertebra is involved, paradiscal, arterial spread, central, which is usually by venous spread, anterior is by subperiosteal spread, and appendiceal or neural arch followed by synovial. Investigations include general routine complete hemogram with ESR and CRP which is raised, and biopsy in case of doubt. Smear and culture is the gold standard, that is usually we will do Ziehl-Neelsen stain as well as culture includes LJR, Lowenstein-Johnson culture medium, and Bactam for faster culture of the microbiome tuberculosis. Imaging modalities, conventional radiographs include X-ray. There will be early detection, better anatomic localization, but disadvantages include the soft tissue cannot be evaluated properly, spinal cord and the neural elements. Well, MRI is a modality of choice where you can see early disease, skip lesions, meningeal involvement as well as planning the surgical approach is very much important. The management includes early diagnosis, expeditious treatment with ATT, DOTS therapy, aggressive surgical approach, and prevention of the deformity. So the present management includes treatment with the ATT, radical surgery, monitoring, radiographs and ESR at 3 to 6 months interval, MRI at 6 months interval for 2 years. Gradual mobilization encouraged in the absence of neurological deficit. Indications of surgery in POTS spine or POTS paraplegia. Very important, no progressive recovery. Neurological complication develops during the treatment, no recovery during the treatment, worsening of the deficit during the treatment, recurrence of the neurological combination, pressure effects, advanced cases of neurological involvement, including bowel and bladder involvement. Follow-up evaluated at 3 months interval up to 2 years. Clinical evaluation includes weight gain, pain relief, free range of motion, resolution of abscesses, neurological recovery, radiological decrease soft tissue shadow, disappearance of erosions, return of mineralization, graft incorporation, and bony ankylosing. TB hip is secondary only to spine. There is no protein enzyme, only a granulation process. Common sites as per the order: acetabular roof, epiphyses are femoral head, metaphyseal region or femoral neck, followed by crater trochanter, involving the trochanteric fossa. Clinical features: first 3 decades the common stage, limping is the earliest symptom, antalgic gait, pain refer to middle aspect of knee, maximum towards the end of the day, and deformity. Diagnosis as already said, X-ray, CT, MRI with sinus fluid aspiration, biopsy. Early diagnosis and effective chemotherapy is vital to save the joint, depends upon the stage of clinical presentation, includes ATT, absolute bed rest, traction, arthroplasty, arthrodesis, and total hip replacement. TB knee, it is 10% of osteoarthritis tuberculosis involves knee, any age group, pain, palpable synovial thickening, tenderness in the medial and lateral joint line, and patellofemoral synovial joint is the most common symptom. Culminating variety in case of children. TB elbow, 2 to 5% cases involves TB elbow. Most frequent sites include medial and lateral condyles of humerus, articular surface of olecranon and head of radius, rarely synovial in origin. Headache will include osteoporosis, blurring of cortex, and periosteosis. Tubercle risk of start bones called TB dactylitis. Primarily childhood, hands is involved more than feet. Short tubular bones are involved. Marked swelling often follows a beginning course. The differential diagnosis would be enchondroma of the